Hello everyone, my name is Rashida Shah and I'm going to be sharing a case presentation today. The chief complaint. So this is a 76-year-old male who came in for shortness of breath, cough, wheezing, and fatigue. His shortness of breath is worse when he walks up and down the stairs or completes strenuous tasks. It is relieved by taking an albuterol and beclomethasone dipropionate inhaler. This shortness of breath and wheezing has lasted for 1 week and it's been worse the past 3 days, and he has 0 out of 10 pain. History of present illness. So this patient is a 76-year-old male who came in for shortness of breath, cough, wheezing, and fatigue that lasted 1 week. Cough and wheezing have been worse in the past 3 days. Patient denies any fever, sweating, or chills and denies any pain. Patient states that he gets out of breath from walking up and down the stairs and it makes his shortness of breath worse. He feels winded just by walking to the mailbox. Patient smokes 1 pack of cigarette a day with 50 pack years, and patient is using albuterol and beclomethasone dipropionate inhaler for shortness of breath relief. Patient has come in before for acute bronchitis, but this was 3 years ago, and he was treated with antibiotics and albuterol. Okay, so review of systems. So for general, the patient does not complain of any fever or chills or pain. For HEENT, the patient does not complain of any headaches or dizziness, no eye pain, discharge or decreased or change in vision, no changes in hearing or ear pain, no nasal congestion, and no adenopathy. For respiratory, the patient is complaining of coughing, wheezing, shortness of breath, fatigue, dyspnea on exertion. For cardiovascular, the patient has some clubbing of the fingernails, but no cyanosis and no palpitations. For GU, the patient says that he has normal urine output and bowel movements once a day, and there's no burning or incontinence. For GI, the patient has a normal appetite, no nausea or vomiting, no constipation or diarrhea, and no abdominal pain. Musculoskeletal, the patient has no joint pain or stiffness and full range of motion in all extremities. For skin, the patient does not have any pallor or cyanosis, but there is some mild clubbing of the fingernails. For neurological, the patient does not have a headache, dizziness, or confusion. And for psychiatric, there are no mood changes noted by the patient. So for pertinent positives and negatives from the review of systems, positives, the patient is positive for productive cough, wheezing, shortness of breath, fatigue, dyspnea on exertion, crackles, and clubbing of fingernails. And for negative, the patient does not have any fevers, chills, eye pain, ear pain, nasal congestion, nasal pain, adenopathy, cyanosis, pallor, palpitations, or barrel chest. For past medical history, the patient has a history of hypertension and hyperlipidemia. Patient has not received his flu vaccine for the last few years. Patient has never had the pneumonia vaccine. Patient drinks around 3 12-ounce beers during the week. Patient is nicotine dependent and usually smokes 1 pack a day and has a history of 50 pack years. Patient has no past history of surgeries or hospitalizations, and the patient's visit to the clinic was 3 years ago for acute bronchitis. Okay, for social history, patient is married to his wife for 45 years and has a son and daughter who does not live with them. The patient is retired but worked previously as an auto mechanic. Patient smokes daily 1 pack of cigarette daily, and patient drinks beer 3 times a week. Patient denies any illicit drug use. Patient usually sleeps 6 to 7 hours every night and denies having sleep apnea. And patient eats home-cooked meals that are made from his wife and occasionally eats out and has fast food on the weekends. Patient does not really exercise because he is easily out of breath, so he says he just usually does not exercise daily. For family history, the patient's father had hypertension and diabetes mellitus type 2. Father died from a heart attack at the age of 70 years. The patient's mother had hypertension and died from breast cancer, but the patient does not remember the exact age, but he said it was in her 60s, and patient does not remember his grandparents' medical history. The medications that the patient is currently taking is lisinopril 20 milligrams for his hypertension, atorvastatin 20 milligrams for his hyperlipidemia. Patient is taking albuterol 90 mcg inhaler, 2 puffs, and beclomethasone dipropionate 80 milligram inhaler for managing his shortness of breath and wheezing. The patient is also taking ibuprofen for any general pains that he has, and he's taking guaifenesin cough syrup for his cough that he's having. Okay, so the vitals were taken first, and the patient's temperature was 97.8 degrees Fahrenheit. His pulse was 80. His respirations were 18. His blood pressure was 145/85, and his oxygen SpO2 was 95%. He has a BMI of 26.1. His weight is 187 pounds, and he is 5'9" tall. Okay, so for the physical exam, the patient appears to have mild respiratory distress, and he uses his accessory muscles when he's breathing, but there's no tripoding. For psychiatric, the patient is cooperative, but he seems a little anxious, but he does have normal judgment and affect on the exam. For his skin, hair, and nails, patient has mild clubbing of the fingernails. His hair is evenly distributed, and there's no pallor or cyanosis present. For his lungs, upon auscultation, there was diffuse wheezing and crackles noted in both the upper and lower lung fields. Labored breathing with accessory muscle usage was also noted, and there was symmetrical expansion of the chest noted, but there's increased resonance to percussion, and there's decreased breath sounds throughout. For the ENT mouth, it was pink and moist without any exudates or lesions. The neck was supple with no adenopathy noted. Heart was RRR with no murmur or gallops. Neurological, he was alert and oriented ×4, and his cranial nerves 2 to 12 were intact. His eyes were Perla plus and EOM plus, and his ears were TM intact with no arrhythmia or discharge. His musculoskeletal was 5 out of 5 strength in all extremities, and he had full range of motion in his neck and his arms and legs. For GI, the abdomen was non-tender, and there was normal active bowel sounds in all 4 quadrants. For GU, the patient deferred the exam, but he admits to normal urine output and bowel movement. Okay, so the diagnostic tests and imaging were done in order to have a differential diagnosis. The primary care provider suspected COPD with exertion. So this is what he was suspecting based on the physical exam and history that was taken from the patient. And FEV1 over FVC, which is a pulmonary function test, was done, and it was found to be 0.60. And chest x-ray was also ordered, because the patient had not previously had one, and there were air pockets, bullae, and hyperinflation of the lungs found upon the chest x-ray. The CBC was done because the patient was complaining of fatigue, and it ruled out anemia. The H&H and RBC were within normal range. A BNP was also done to rule out heart failure, and a CMP was done to check the electrolytes of the kidneys, and everything was within normal range. The BUN, creatinine, and sodium, potassium, and the GFR were all within normal range. So this is a list of the differential diagnoses that were made. For asthma, this is a reversible condition with treatment, but because the patient has had wheezing and shortness of breath for a long time, along with a smoking history and decreased breath sounds, the primary care provider was thinking more that the patient had COPD with the exacerbation instead of asthma. And also because the chest x-ray reveals hyperinflation of the lungs along with bullae. For acute bronchitis, the coughing has been going on for a longer time, and the chest x-ray and pulmonary function tests do not indicate that this is an acute condition. For pneumonia, the patient did not have any of the other symptoms of pneumonia, such as fever, and the CBC revealed a normal white blood cell count. So the provider did not consider pneumonia to be the diagnosis. For congestive heart failure, the BNP was normal, and the patient had normal heart rate and rhythm. So this was ruled out also. So the main primary diagnosis that the provider was considering was COPD with exacerbation. So the primary diagnosis that was made was marked by worsening symptoms, including dyspnea, productive cough, wheezing, and fatigue. Patient has had a long history of using albuterol inhaler, and his O2 sat is worse. It's 95%. The pulmonary function test was 60%, which indicates moderate COPD. The chest x-ray included hyperinflammation of the lungs and bullae, which are irreversible. There's a long-term smoking history. So all of these test and the history and physical exam indicated that the primary diagnosis is COPD with exacerbation. Okay, so for the treatment, the primary care provider gave nebulized treatment with albuterol and ipratropium bromide in office to improve the SpO2 from 95% to 97%. Then the primary care provider prescribed a 5-day course of oral prednisone, 60 milligrams once a day for 5 days. This is highly recommended by the clinical guidelines for COPD exacerbation. Also, antibiotics are highly recommended for COPD exacerbation to reduce mortality, and so basically a 5-day course of azithromycin antibiotic 500 milligrams was given on day 1, and then 250 milligrams once a day for day 2 to 5 was prescribed, and then the albuterol and beclomethasone was refilled. The primary care provider also prescribed the antimuscarinic agent tiotropium 2 puffs via inhalation once daily. The primary care provider gave a non-pharmacological treatment of nasal home oxygen 2 liters and a referral to a pulmonologist, and the primary care provider educated the patient on emergency precautions if symptoms worsened, and the patient was supposed to follow up in 5 days. The patient was educated on COPD diagnosis and the complications that can occur if the patient does not manage the COPD, which include cor pulmonale, pneumothorax, and respiratory failure. The patient was also educated on stopping to smoking and smoking cessation and the benefits of that. The patient was also educated on the importance of influenza and pneumonia vaccine. The patient has high blood pressure, so he was also educated on the DASH diet, and nutritional support also helps with COPD exacerbation. Patient was educated on the importance of exercise and not overdoing it, but at least having some sort of daily exercise routine. Patient was educated on using the oxygen therapy, and then also to note for any emergency symptoms and refer to the ER if conditions worsen. So the clinical practice guideline that was used was from the American Family Physician Journal. The pharmacological treatments that were highly recommended from this guideline were corticosteroid therapy, which was prescribed to the patient, antibiotic therapy, and antimuscarinic agent and beta agonist for treating COPD exasperation. Some non-pharmacological treatments that were highly recommended from the guideline were oxygen therapy, which was provided to the patient. He received 2 liters of oxygen therapy, nutritional support, chest physiotherapy, and early pulmonary exercise treatment. And these are the references.